Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoyed today's podcast.
Good afternoon. I'm Dr. Craig Nunemaker, Associate Professor of Biomedical Sciences at Ohio University's Heritage College of Osteopathic Medicine and member of the Evidence-Based Library Working Group for Cardio's Team Best Practices. My research focuses on therapeutics that act on the insulin-producing beta cell to treat type 1 and type 2 diabetes. I'm here with Dr. Kathleen Dungan, Professor of Medicine and Endocrinologist at The Ohio State University and co-lead for Cardio's Team Best Practices. Welcome, Kathleen.
Thank you for the kind introduction, Craig. I'm thrilled to be here.
As many of our listeners know, diabetes and cardiovascular issues are closely linked. In fact, the American Heart Association reports that if you have diabetes, your risk of developing cardiovascular disease is more than double that of the general population. In this podcast, we will discuss the atypical forms of diabetes, including when to suspect and diagnose them, as well as approaches for treatment. So, Kathleen, we are well aware that most people with diabetes are classified as having either type 1 or type 2. In most cases, they present very differently, and it's not hard to tell them apart. However, as a scientist who studied insulin-producing cells and diabetes for over 20 years, I know the pathophysiology of diabetes is very complex. What are some of the more common pitfalls in the classification of type 1 and type 2 diabetes?
Well, you are exactly right, Craig. Type 1 diabetes is an autoimmune disorder, as we know, leading to destruction of pancreatic beta cells and usually leading to absolute insulin deficiency. Type 2 diabetes, on the other hand, refers to progressive beta cell dysfunction, frequently in the presence of insulin resistance. However, there are many situations where it's not so easy to differentiate between persons with type 1 or type 2 diabetes. Youth with type 1 diabetes typically present with rapid onset of symptoms and often have diabetic ketoacidosis, while adults, on the other hand, might have a much slower, more indolent course. In fact, while the incident rate of type 1 diabetes is higher in youth, over half of individuals with type 1 diabetes are diagnosed as adults. Couple that with the much higher prevalence of type 2 diabetes and background obesity and other risk factors for type 2 diabetes, and it can be easy to see why 40% of adults with new onset type 1 diabetes are initially misclassified as type 2 diabetes. Another term for slowly progressing type 1 diabetes is latent autoimmune diabetes in the adult, otherwise known as LADA. Now, LADA is a more prevalent condition in Northern Europe and China, and less so in those who identify as Black or Hispanic. But the American Diabetes Association classifies LADA as type 1 diabetes.
Okay, well, would you comment on the opposite scenario in which type 2 diabetes is misclassified as type 1?
Yes, what's even more confusing is that type 2 diabetes can present in some populations, particularly those who identify as Black or Hispanic with diabetic ketoacidosis, otherwise known as DKA, and this is termed ketosis-prone diabetes. Thus, youth in particular can be misdiagnosed as having type 1 diabetes in the absence of a careful evaluation. However, the underlying pathophysiology is not autoimmune at all. Once diabetes is effectively treated, typically with lifestyle changes or medication, about half of individuals initially presenting with DKA who have normal C-peptide and negative autoantibodies may be able to come off of insulin entirely. And there are some individuals with a single elevated antibody who have an intact C-peptide who have features of both type 1 and type 2 diabetes. If there is a history of DKA, this should generally be treated with insulin, with or without non insulin therapies. Often, a referral to an endocrinologist is appropriate, especially when the classification is unclear.
Yeah, so that could make a huge difference in a person's health and quality of life. If a person has slowly progressive type 1 diabetes, why shouldn't we just approach them as having type 2 diabetes?
Well, Craig, it's true that these individuals can respond to non insulin therapies, and sometimes for many years, particularly if they also have other features of metabolic syndrome. It is important to recognize these individuals because they require insulin sooner than individuals with type 2 diabetes, and they have a higher long term risk of complications. Sulfonylureas should be avoided, however, because of concern that they may hasten beta cell demise. Sodium glucose cotransporter 2 inhibitors, otherwise known as SGLT2 inhibitors, should be used with caution due to the risk for DKA in these individuals. If used, I would recommend education on monitoring, discontinuation during periods of illness or prolonged fasting, and periodic C peptide and glucose testing. If the C peptide is low, I would avoid SGLT2 inhibitor use in the vast majority of patients.
Okay, so Kathleen, what can healthcare providers do to sort this all out?
Well, for type 1 diabetes, the most discriminating features are younger age, less than 35 years, lower body mass index, less than 25, unintentional weight loss, ketoacidosis, and severe hyperglycemia greater than 360 milligram per deciliter at presentation. A helpful mnemonic is AABBCC, and this stands for age and autoimmunity, which is a personal or family history of other autoimmune disorders. B, which is body habitus and background, including family history or type 1 diabetes or other autoimmune disorders. Control is the C, and that's glucose control. And comorbidity, such as treatment with a checkpoint inhibitor for cancer, that's the other C. I also incorporate family history of diabetes, as the majority of individuals with type 2 diabetes have a first degree relative with diabetes. I would recommend that PCPs or primary care providers consider testing in anyone who is young or lean in particular. However, these features are not absolute, and the correct classification may only become apparent over time. For example, an individual with less discriminating features of type 1 diabetes who's not responding to non insulin therapies can and should be tested for type 1 diabetes.
Okay, thanks. I like that AABBCC. I'll remember that one. So, what about diagnostic testing?
For anyone with possible type 1 diabetes, testing for the 5 autoantibodies, such as glutamate decarboxylase isoform 65, otherwise known as GAD65A, should be performed. The GAD antibody is the most prevalent antibody, but false positives can occur, and the presence of multiple positive antibodies and or higher titers increases the specificity of testing. For those with lower likelihood of type 1 diabetes, you can start with the GAD antibody, but in higher risk cases, all antibodies should be obtained, especially if the GAD antibody is negative. Among individuals who have had diabetes for many years, it's important to note that the autoantibodies may become undetectable over time. The C peptide is often normal at the time of diagnosis. However, it typically declines over time, and your glucose levels become more difficult to manage. This over time makes the clinical diagnosis more clear. The C peptide should be obtained from a random, that is a non fasting sample, ideally, and interpreted within the context of a concomitant glucose level, ideally 144 milligram per deciliter or greater. If normal, the C peptide should be measured periodically or annually where the diagnosis is unclear.
Well, it's good to know that patients do not need to fast for this testing. So, I wanted to shift to another situation where patients can be misclassified, and that's monogenic diabetes. What is monogenic diabetes, and when should we suspect it?
Well, While type 2 diabetes is considered polygenic, several forms of monogenic disorders are well known. Mutations can be non syndromic or have syndromic features and include neonatal diabetes and older youth or adult onset forms that collectively were formerly known as maturity onset diabetes of the young, or MODY. Non-syndromic mutations typically affect beta cell development or function. Monogenic diabetes is typically inherited on an autosomal dominant basis and accounts for 1 to 5% of cases of diabetes. It should be suspected in individuals diagnosed as children or young adults, generally under the age of 25, with a strong family history and without other clinical features of type 1 or type 2 diabetes, such as obesity or the type 1 diabetes autoantibodies. Individuals commonly have an intact C peptide and a mildly elevated A1C. When these forms are suspected, patients should be referred for genetic testing or to an endocrinologist. An online MODY calculator based upon a Swedish cohort is available from diabetesgenes.org. The calculator is linked in our show notes today. According to the American Diabetes Association guidelines, testing should be performed if the model probability is greater than 5%.
Hmm. So, what is the most common type of monogenic diabetes, Kathleen?
There are really two types that are most common. The first one is a mutation in the glucokinase or GCK gene, and it's formerly known as MODY2. And this accounts for 30 to 50% of all monogenic diabetes. It's characterized by increased threshold for glucose stimulated insulin secretion, and this results in mild fasting hyperglycemia that typically doesn't require any treatment, except during pregnancy. The second mutation is in the hepatic nuclear factor 1 alpha, or HNF1A, and this is formerly known as MODY3. And again, it accounts for 30 to 50% of all monogenic diabetes cases. This is characterized by reduced renal threshold for glucosuria, postprandial hyperglycemia, and it's very sensitive to sulfonylureas. In some cases, kids who are originally diagnosed as having type 1 diabetes are able to discontinue insulin completely when the diagnosis is made correctly. The beta cell secretory defect is progressive, and individuals are at increased risk for complications.
Huh. Are there unique features of monogenic diabetes that can help healthcare providers recognize it?
Yes, HNF1A, otherwise known as MODY3, and HNF4A, otherwise known as MODY1, are similar in presentation and prognosis. And these patients may have a history of being large for gestational age at birth and or neonatal hypoglycemia. So if you can get a birth history, that might be helpful. HNF1B, which is also known as MODY5, features pancreatic atrophy, renal abnormalities, and hypomagnesemia.
All right. Well, so another topic I wanted to cover is syndromic diabetes. As you know, some mutations leading to diabetes involve multiple organ systems and can be categorized as syndromic diabetes. What are the common syndromic forms of diabetes?
That's right. There are many examples of syndromic forms of diabetes. Wolfram's syndrome is a very rare autosomal recessive disorder that's characterized by dysfunction of the endoplasmic reticulum and results in diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Mitochondrial diabetes is another one, and it accounts for up to 3% of all cases of diabetes. It is maternally inherited disorder of mitochondrial function. And mitochondrial diabetes are clinically heterogeneous disorders and include deafness, myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. The importance of these forms of diabetes is that metformin should be avoided due to the risk of lactic acidosis.
So, early onset diabetes and deafness may be a clue for the need for genetic testing. Now, there's also lipodystrophy, which is a unique cause of diabetes that can be inherited or acquired. When should we suspect that?
Yeah, lipodystrophy is actually pretty fascinating because it is caused by the loss of body fat rather than too much of it. But it can be hard to distinguish from type 2 diabetes in that both have features of insulin resistance. This is caused by ectopic fat deposition and results in dysfunction in multiple organs. Patients with lipodystrophic forms of diabetes can be easy to miss due to variable loss of fat, but they may have severe insulin resistance that's out of proportion to their weight. It's important to recognize as complications and comorbidities can be severe and present early in life. Some of these comorbidities include hypertension, severe hypertriglyceridemia. Sometimes this leads to pancreatitis and metabolic liver disease. Patients commonly develop early atherosclerosis as well. And some forms of lipodystrophy are also associated with cardiomyopathy, arrhythmias, non diabetic proteinuria, and neuropathy. Diabetes can be treated with insulin sensitizers like metformin and pioglitazone, and high dose, sometimes even concentrated insulin is required. Metroleptin is another option. It is approved for treatment of generalized forms of lipodystrophy.
So, there are also disorders of the exocrine pancreas. What should primary care providers know about pancreatic diabetes?
Well, pancreatic diabetes is sometimes called type 3C diabetes. It's relatively common and includes a heterogeneous mix of disorders of the exocrine pancreas, such as acute and chronic pancreatitis, cystic fibrosis, and pancreatic cancer. Diabetes risk is increased about twofold after even a single episode of acute pancreatitis. Thus, the American Diabetes Association recommends screening every 3 to 6 months after an acute pancreatitis episode. There's limited evidence for preventive strategies, but screening annually thereafter seems reasonable. Once diagnosed, treatment should include metformin, which may also confer some survival benefit. On the other hand, GLP-1 based therapies and dipeptidyl peptidase inhibitors are generally avoided due to the possible concern about causing pancreatitis or pancreatic cancer. The evidence is really unclear. SGLT2 inhibitors may be considered in patients who are not severely insulin deficient due to the risk for diabetic ketoacidosis. Consider also checking a C-peptide and glucose level prior to initiating the SGLT2 inhibitors. And then finally, insulin therapy is needed more commonly in these patients than in persons with type 2 diabetes without pancreatitis or other pancreatic disorders. In the case of chronic pancreatitis, diabetes can be indistinguishable from type 1 diabetes and also accompanied by impaired alpha cell function, meaning that patients are at particular risk for severe hypoglycemia. And this is compounded by any ongoing gastrointestinal symptoms and sometimes unpredictable eating patterns associated with chronic pancreatitis. In patients with cystic fibrosis, annual screening is recommended using an oral glucose tolerance test, and it's recommended starting at age 10.
Okay, so there are several classes of medications that can contribute to hyperglycemia and even diabetes, correct?
Yes, that's true. Acute or chronic systemic steroids can cause significant hyperglycemia and diabetes. Treatment can utilize non insulin therapies, but often requires insulin therapy, and it should be tailored to the duration of action of the steroid. Atypical antipsychotic medications like olanzapine are also a concern, leading to guidelines for frequent diabetes screening at baseline, 12 weeks, and also annually. Numerous cancer therapies that impact metabolism or the immune system can also contribute to the development of diabetes. Immunomodulating therapies, especially those involving programmed cell death 1 pathways, can increase the risk of type 1 diabetes. And in particular, this can be fulminant and lead to DKA within a matter of days. Therefore, anyone with recent exposure to these medications who develops diabetes should be assumed to have type 1 diabetes and treated with insulin until proven otherwise. Alpelisib is a breast cancer therapy that interferes with insulin signaling and leads to hyperglycemia in about 60% of individuals. Preferred treatment is metformin, SGLT2 inhibitors, or pioglitazone. Finally, we can't forget about post-transplant diabetes, which might be influenced by exogenous glucocorticoid use, but also anti-rejection medications, including tacrolimus and calcineurin inhibitors. Management typically necessitates team-based care, taking into account the frequent adjustment in medications and comorbidities related to the transplanted organ.
Wow, I really didn't know there were that many atypical forms of diabetes. It truly is a complex disorder, isn't it?
I'm sure you can appreciate that. Keep in mind that many endocrinopathies, such as Cushing's syndrome, pheochromocytoma, thyrotoxicosis, acromegaly, can also cause or exacerbate diabetes, and this is due to the complex interplay of the endocrine system.
Well, Kathleen, thank you very much for clarifying such a complex topic. Do you have any final comments for our listeners?
Yes, an understanding of these atypical forms of diabetes has been key as we enter an era of precision medicine. It's important to remember that much of the research in precision medicine approaches for diabetes has been conducted in higher income populations with European ancestry. Unfortunately, specialized testing is more likely to be performed at large academic centers, and while little evidence is available, this could cause significant disparities in diagnosis across racial, ethnic, socioeconomic, and geographic groups. Thus, there's a critical need to understand and include more diverse populations in order to eliminate these disparities. An understanding of these atypical forms of diabetes has been key as we enter this era of precision medicine. We're increasingly aware of important phenotypes that not only inform risk for diabetes, but also risk for complications, and one day might help us to understand and tailor therapy in persons with type 2 diabetes as well.
Well, thank you, Kathleen, for speaking with us today.
It was great to be here.
And a special thanks to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.